So we're going to start with that first beta-lactam class, the penicillins. I mentioned that we have subclasses. The first ones are the natural penicillins, and those were the ones that we identified from natural sources. These had little activity against gram-negative. So we start out with very much focused on gram-positive activity. Unfortunately, these are also very vulnerable to beta-lactamases, and so they can be pretty hard to use by themselves. We then went to amino penicillins, and we include ampicillin and amoxicillin. You can remember AM for amino. These were somewhat improved against gram-negative, and they still had gram-positive activity, but again, still very vulnerable to beta-lactamases. So when you use those, you often see them with a beta-lactamase inhibitor. We then wanted to create a class that would have better activity against Pseudomonas. So we have those anti-pseudomonal penicillins, and pipracillin and ticarcillin are two of those. You need to know pipracillin, and P is for pseudo, for Pseudomonas. They had even better activity against gram-negative, and they still had good gram-positive. They're still vulnerable to some beta-lactamases, but not to as many beta-lactamases as are the natural and amino penicillins. So then more recently, there became more of a focus on making beta-lactamase resistant penicillins. We also call those antistaphs, and those are your NODs, nafacillin, oxacillin, and dicloxacillin. These guys were focused directly on being able to be used against staph and strep. So they got rid of all gram-negative activity. They said, we don't care about that as long as it works for staph and strep and is resistant to their beta-lactamases, then we're happy. So all of these are going to have gram-positive activity, but they're going to vary in their gram-negative activity. So when we talk about antibiotics, I'm going to give you some example drug names, the mechanisms of action for that drug class. I'm not going to ask you to memorize whether they're cidal versus static, but it's a nice thing for you to have at least seen. I'm going to tell you the gram specificity, and if there's some specific or special information about those particular drugs, then we're going to talk about that as well. And finally, I'm going to give you specific adverse effects if appropriate. So for the penicillins, all of them are going to have the same molecular and cellular mechanism of action. They're going to irreversibly suicide inhibit PBPs, or transpeptidase. That's going to block the cell wall synthesis, and it's going to cause the bacteria to lyse, or break open. Those natural penicillins, we had penicillin G, penicillin V, and penicillin VK, or VTIDs. Remember, these natural penicillins had very little activity against gram-negative. They have a reasonably common risk of allergy. So about 10% of patients have true allergy. Any allergies to one of these penicillins, there's going to be allergy to the other ones as well. And these guys were very vulnerable to beta-lactamases. Some of the specific things are going to be that hypersensitivity, that socks and gloves rash. And hypersensitivity means true allergy. At high doses, they can cause seizure. That doesn't have anything to do with the antibiotic activity. It has to do with the fact that they actually have some mild antagonism at GABA A receptors. So you reduce GABA A activity, that reduces tonic inhibition in the brain and makes you more likely to be able to have excitation and seizure production. So at high doses can cause seizure, hypersensitivity. They can also be nephrotoxic, and that's because of that hypersensitivity reaction. So if the kidneys themselves are having this hypersensitivity or an allergy type reaction. These are excreted renally, so if someone has renal impairment, that's a contraindication. And they also can have the side effect of a black and hairy tongue. Next, we have amino penicillins. We have ampicillin. We have amoxicillin, which is amoxil or moxitag. And then we have the combinations of these with beta-lactamase inhibitors. So amoxicillin and clavulanate is augmentin, and ampicillin and sulbactam is unison. This was that second generation of penicillins, so it had somewhat improved activity against gram-negative, but still not that much activity. and it has good gram-positive. These can have cross allergies with other penicillins, and they're very vulnerable to beta-lactamases. Specific adverse effects, they're going to be same as natural penicillins, so seizure, hypersensitivity, nephrotoxicity. But one specific thing to remember is that augmentin itself has a very high frequency of diarrhea. The anti-pseudomonal penicillin that you need to know is pipracillin, and that comes with its beta-lactamase inhibitor, tazobactam, to make Zosyn. These are going to have further improved activity against gram-negative, so there's more of that now. Still have your gram-positive, and same thing as all the other penicillins, the cross allergies, and some vulnerability to beta-lactamases, but not as much as the previous classes. And the adverse effects are going to be the same as the other penicillins. And then that last penicillin group, the antistaph penicillins, we have nafcillin, oxacillin, and dicloxacillin. And these guys were specifically created to have good activity against staph and strep, but by doing so, you lost activity against others. And these are only gram-positive activity. So we've got all of those normal psyllin cross allergies, but low vulnerability to staph beta-lactamases, so they don't get broken down as easily. And then the adverse effects are the same as the natural penicillins. So we've covered penicillins, and we're going to move on to cephalosporins. Cephalosporins have the same mechanism of action. They irreversibly suicide inhibit PBPs or transpeptidase, and they block cell wall synthesis, causing the bacteria to lyse. Again, beta-lactams. These have even more generations and even more drugs. So there are some different schemes of distinguishing the generations, but what we're going to look at here are the commonly occurring first, second, and third generation agents, and then more recently added anti-pseudomonal and anti-MRSA. So as we talked about before, with the cephalosporins, they started out with a lot of gram-positive, and then we decreased their activity against gram-positive while increasing the gram-negative. Then at that point, then our med chemists said we need something that's broad spectrum, and they created these anti-pseudomonal and anti-MRSA. So these are the cephalosporins that you need to know, and you need to be able to identify which generation they're in. So first generation has cephalexin and cefazolin. The second generation is cefuroxime, cefacetin, cefotidin, and cefaclor. The third is ceftriaxone, cefotaxime, cefdinir, cefixime, and cefpodoxime. The anti-pseudomonals include cefepime, ceftazidime, and ceftolozine, and the anti-MRSA is ceftaroline. And yes, I managed to say all of those. So is this just me being cruel? No, it isn't. Pharmacists do have to know which generation these are in, and they talk to each other about them, referring to those generations as well. So I'm going to kind of describe this first, second, and third generations together, in that what you really want to know is that change in gram-positive to gram-negative activity as you go through the generations. You also want to know that while these have a beta-lactam group, that group is more hidden. So while you can have cross-allergy with psyllins, it's less common. So only about 1% of patients are going to have a cross-allergy between penicillins and cephalosporins in these first generations. They're also, as far as cephalosporins, fairly vulnerable to at least some beta-lactamases. The third thing that I want you to know is, and we're only going to talk about this with cefdinir, it's what we call a di-tri antibiotic. And you're going to see some other di-tris in the future. So what we're calling a di-tri is any drug that's going to bind or chelate divalent or trivalent cations. So if you've got your drug here and it's going to bind, say, calcium and affect the permeability of the drug or the activity of the drug or the absorption of the drug, then you're going to want to think about what types of effects it has. In the case of cefdinir, it binds calcium, which is included in dairy products, magnesium, iron, aluminum, and bismuth, and those are given as supplements or components of antacids. So when cefdinir binds to any of these trivalent cations, it actually reduces the absorption of the drug. So you want to know that this has that counseling point of not taking with dairy products or these cations, and that the reason for that is reduction of drug absorption. The specific adverse effects of the first 3 generations of cephalosporins include the same things you would normally see with the penicillins, that's seizures, possible anaphylaxis. We already said that cefdinir chelates the ditries, and that's going to decrease drug absorption. And we also want to note that ceftriaxone, the drug, is excreted with the bile, and then as it travels down the GI tract, it can be reabsorbed, and that's going to keep it around longer. Neonates don't have really good bile excretion abilities. That's why they can get jaundice pretty easily. And ceftriaxone itself is avoided in neonates because it can cause biliary sludging. The anti-pseudomonal and anti-MRSA cephalosporins are broad spectrum. They have infrequent cross-allergy with penicillins. Again, only 1% of patients. They're vulnerable to some beta-lactamases, but the latest generation is not susceptible to MRSA beta-lactamases. So MRSA has specific genetic code for specific beta-lactamases, and this drug isn't broken down by those yet. Specific adverse effects include those of all the other beta-lactams with seizures and anaphylaxis.